Perspectives on Emerging AD Therapies. Hello everyone, and thank you for tuning in. In this episode, we're joined by Dr. Leon Kircik to discuss recent advances and emerging treatments for atopic dermatitis. Dr. Kircik, why has atopic dermatitis lagged behind psoriasis in terms of approved targeted treatments?
So that's really a well-deserved question that we don't think about it that much. But when we look at the history of the development of psoriatic biologicals, it actually goes back to rheumatoid arthritis and psoriatic arthritis. So if we think about all the TNF-alpha inhibitors that came to the market initially, they came back from the back door. Most of them were approved for first rheumatoid arthritis, then they got approved for psoriatic arthritis, and finally they got approved for psoriasis. So it's sort of a afterthought. Psoriasis was sort of an afterthought, and that's why they were very successful. They have been in the market for a very long time. And then the second and third generation biologics followed that, but they did not follow the same route. Actually, when you look at IL-17s and IL-23s, first they got approved for psoriasis, then for psoriatic arthritis. So sort of the route was reversed at that point. And also we had a better understanding of pathophysiology of psoriasis. So when you have a better understanding of the pathophysiology, you're certainly going to be better at finding drugs that we know the mechanism of action, that we can target certain cytokines such as IL-17 and IL-23. Unfortunately, our understanding of the atopic dermatitis is not at the same level yet. We're still trying to find the role for IL-4, IL-13, and other major cytokines that play a role in pathogenesis of atopic dermatitis, and hopefully we will get there soon, because the development in targeted treatments for atopic dermatitis is moving at a much faster rate than the one it happened for psoriasis.
What are some of the most promising therapies that will likely be part of the AD treatment table in the near future?
So I think these are really exciting times for development in atopic dermatitis. As you may know, a large portion of my business is actually clinical studies. And we are doing so many different clinical studies for atopic dermatitis. We have several biologics in the pipeline targeting IL-13, actually different biologics targeting IL-13. We have an anti-TSLP product. We have several JAK inhibitors. So not only we have biologics, but we also have small molecule systemic medications such as several different JAK inhibitors. But also, ironically, for a long time we did not have much in the topical market. Well, now we have several new topical JAK inhibitors again in development, as well as topical PD4 inhibitors in development. So we are actually very lucky, and it's very exciting times to be in atopic dermatitis clinical studies. We have so much in the pipeline.
Do you foresee that these therapies will also be approved for pediatric AD or only for the adult population?
So that's a really great question. And when we look at the development of the first biologic, dupilumab, usually the agency follows and requests them, of course, to get the approval for the adult patients, 18 and above. And then the approval came from 12 and above. And then very, very recently, the approval came 6 years of age and above. So there's always this different age groups that we usually get pediatric approval to make sure that the safety is there for the adult population and the adolescents and then the younger population. That's usually how it goes, most of the pediatric studies. Ironically, recently, lebrikizumab, which is the IL-13 inhibitor, and that actually we're doing studies 12 and above from the get-go. So agency had decided that we can actually include those patients without the adult improvement first, and that's very, very promising. We also have several topical products that, as I mentioned earlier, that we're going back and have patients included 12 years of age and above. So we are doing early phase 3 studies, including those pediatric population. After all, we do need those new drugs for our pediatric population with atopic dermatitis, because our majority of patients with atopic dermatitis are still pediatric population. So we do have a big need. It's a big unmet need to have drugs to cover those patients, and we are getting there.
In terms of assessing disease severity, how practical are the scales used in clinical trials? Should we put more emphasis on patient-reported outcomes?
So, again, this is a very relevant question. As I mentioned, a major part of my business is clinical trials, but I also see regular clinic patients. And it's very interesting how we do this and how we separate these two entities. We have to understand, I think it's very important for clinicians to understand that clinical studies are done to get the drug approved. In order to get a drug approved, we have to meet certain criteria required by the agency in this country. And when we look at those different assessments, we have EASI score, we have SCORAT, we have IGA, we have several different questionnaires and PROs. But really, do all these different assessments matter when it comes in real life in clinical practice? And how are we assessing those patients? You know, originally when we had psoriasis and we did the psoriasis studies, right, and we still do it, we have IGA, which is Investigator Global Assessment, or PGA, Physician Global Assessment, which is an overall looking at that patient and decide the severity of the disease, which range from all the way from 0, which is clear, 1 is almost clear, 2 is mild, 3 is moderate, 4 is severe. And then we had body surface area, which actually is difficult to measure because it's the patient's palm, and you know it's difficult to eyeball that. But we sort of got used to that because most of the third-party payers, if they want the patients to have at least 10% body surface area to qualify for a biologic treatment. So we have overcome that hurdle, and most of us now document patient severity in the chart as well as the body surface area in clinical assessment. But we still don't do PASI. I don't think it's relevant. I don't think it's easy to do it. It takes a lot of time, and it doesn't get us anywhere. But, however, we use PASI in every clinical study, right? It's actually PASI 75 is the assessment that requires agency approval in this country. Now, having said that, it's very similar to atopic dermatitis. We have EASI, we have SCORAT, we have IGA. We have actually one assessment. It's, I think, in my mind, it's the most important when it comes to atopic dermatitis is the itch score, right? Pruritus is the most disturbing symptom of atopic dermatitis. So, I think, to summarize it, in real life, in our clinic patients, what we do, we eyeball the patient, and we decide if that patient is mild, moderate, or severe, and then we sort of niche it or think in our mind, put it in a box that we're going to treat that patient systemically or topically, and we do the same thing for psoriasis. So I call that IGA eyeballing, right? The IGA is the official name, Investigator Global Assessment, in clinical trials, but I call that an eyeballing in our everyday clinical practice, which is very relevant. Then body surface area has become relevant in order to get those biologics approved in psoriasis, and I believe it's going to be the same for atopic dermatitis, that we are used to it. But every other assessment I don't think, for example, PASI in psoriasis and EASI scoring in atopic dermatitis is quite burdensome, difficult, and most of us in clinical practice are not going to do that. On the other hand, the itch score, I think it's very, very important in atopic dermatitis. It's a very easy assessment that you can ask the patient, from 0 non-itch to 10 being the worst itch, where you are, and to measure that improvement as part of the patient-reported outcome, it's huge. Then we certainly have several other patient-reported outcomes, dermatology life quality index, and other indices that are relevant to certain specific diseases that we don't really do in real life, but we do in clinical studies. And believe it or not, in Europe, those are part of the approval process of a particular drugs, but not here, not in this country yet. But definitely patient-reported outcomes are very, very important. It's important for the success of the drug. It's important for the improvement and outcome. And it's also important when we want to show some improvement to the third-party payers in order to get the drug approved, how the patients perform and how their life actually improved, so that we can request that, request the drug. So the bottom line is, short answer to your question, we have to pick and choose what assessments are relevant in real life compared to the clinical studies.